Yes. Good morning and welcome to the Health and Social Services meeting for January 12th. And we're going to first start out with the roll call. And if you could press that you're here.
Councillor Anderson?
Councillor Anderson, can you hit yes?
Yes.
Thank you. Mayor Carter, could you also accept that you're here?
Oh, he did.
Okay, thank you very much. Got everybody? Okay, perfect. Now we're moving on to declarations of interest. Is there any declarations of interest? And seeing none, I need a mover for the adoption of the minutes for December 8th. Moved by Mayor Foster, second by Councillor Dyes. All in favor? And that is carried. We have no statutory public meetings, and we're going to move over to presentations with our illustrious Dr. Robert Kyle, and who's going to give us a health department overview. Dr. Kyle, please.
So thank you, Chair, and good morning and Happy New Year, committee members. Before I begin my presentation, I want to introduce my executive team. They're all important, so I'm not announcing them in any particular order of importance. They're in the back row and behind me, so I'll start with Pat. So Dr. Pat Abbey, maybe you could wave, is our Director of Oral Health. You may have met her on the tour at our dental clinic in Oshawa. Beside her, to her left, is Kavin Thangaraj. Kavin is our Director of Population Health and Chief Nursing Officer. Beside her is Zara Jaffer. Zara is the Director of Business Affairs. Behind me is Lisa Fortuna. Lisa, if you could wave. Lisa is our Director of Health Protection. Beside her is Dr. Pepe McTavish. Pepe is our Associate Medical Officer of Health, and when I'm away, she is Acting Commissioner and Medical Officer of Health. Beside her, you met at our last meeting, Chief Troy Cheeseborough. He's the Chief of Paramedic Services, and Troy, when he gets to his presentation, will introduce his senior leadership. In terms of my executive team's portfolio, there is a slide that will tell you what programs are in their portfolio. So I'll wait until we get to that. Okay, so hopefully I've got this right. Okay, so this is almost a recap of much of the material I presented to you during your council orientation. So with that in mind, I'll go through the slides fairly quickly. There are a couple of additional slides that provide a bit more information than the deck that I walked you through at your orientation. But for the most part, this is really a recap. So public health, paramedic services, a little bit about us as a department, our accountability framework, and current and future issues. So just as a reminder, in terms of the architecture of public health in Ontario, there are three key ministries that regulate us, and they're listed there. There is a Chief Medical Officer of Health and Associate Chief Medical Officers of Health. Public Health Ontario is the scientific and technical, CDC of the North for Ontario. There is the Office of the Chief Medical Officer of Health and Public Health. And we're one of 34 local public health agencies that consist of a Board of Health, you as council, a medical officer of health, and professional and administrative staff. I'm not going to go through the legislation that impacts public health, The key piece of legislation for public health is the Health Protection and Promotion Act, and there are a number of other pieces of legislation. I forgot to mention that to my left is Aaron Wakeford. Aaron is acting legal counsel to the Health Department and Social Services Department. So sorry for that, Aaron. Under the Health Protection and Promotion Act, there is a key foundational document, the Ontario Public Health Standards. They define what we do and how we do it for standardization purposes across all 34 public health units. And funds are flowed to us from the province through a public health funding and accountability agreement. Again, as a reminder, there are key pieces of sections under the Health Protection and Promotion Act that concern you as our Board of Health. The key sections are listed there, and I'll go through them in a bit more detail. So as our Board of Health, you're responsible for ensuring the provision of mandatory school and optional health programs and services. You have to ensure compliance with the regulations under the Act, and you have to ensure compliance with the Ontario Public Health Standards, protocols, and guidelines as they affect the health programs and services that we're required to provide. You are required to provide oversight of parts 2, 3, and 4 of the Act relating to the mandatory health programs, community health protection, and communicable disease control. You are required to appoint a medical officer of health, and you may appoint one or more associate medical officers of health, and their appointments have to be confirmed by the Minister of Health. And you're responsible to have qualified professional and administrative staff. In terms of the role of the medical officer of health, and the associate has the same powers and duties as the MOH. First and foremost, I'm required to report to you directly on public health concerns and on our programs and services. And I'll go into how I do that in a later slide. But as I said in the orientation, I report to you, you receive. We have kind of a report-received relationship with respect to the first bullet. I'm responsible for the staff whose duties relate to the delivery of public health programs and services, and any service providers that we've engaged to assist us with delivery. I'm responsible for the management of public health programs and services, ensuring that the health unit is inspected for health hazards, ensuring that occupational and environmental health hazards are investigated and reported out to the appropriate provincial ministries. And as I said, I'm responsible for ensuring community health protection and communicable disease control through the provisions in the HPPA. You are required to pay for the expenses that are incurred by the Board of Health and the medical officer of health. So the region has a dual role. As council, you are a Board of Health, and by law, from a funding perspective, you're considered our obligated municipality. And the payment has to be sufficient to fulfill our mandate. And on an annual basis, on your behalf as our Board of Health, I give notice to the region with respect to the funding that is required from the region. I mentioned that we get funding from the province through a public health funding and accountability agreement. Funding by the region for public health is mandatory. Funding from the province is discretionary. And it's probably important to note that under the agreement, the ministry may conduct an inspection, audit, or investigation with respect to basically how the money is spent and our overall compliance with the agreement. The assessment is a tool in the HPPA that is rarely used, but the minister may appoint inspectors and assessors again to ascertain compliance with the Act, regulations, etc. The minister has the power to give direction to a Board of Health to correct failures that may arise through the assessment, and the minister has powers to take steps to ensure the direction is carried out. This is rarely used. It was used to basically replace the board and MOH with respect to Algoma Public Health, and many years ago it was used to dismantle the Muskoka Parry Sound Health Unit. So extraordinary powers, rarely used. And there are a number of enforcement provisions related to the previous slide. They're listed there. I'm not going to go into them in any detail, but you need to know that some of these provisions are enforceable under the HPPA. With respect to paramedic services on Ontario, and you'll get more information about this in the next presentation from Chief Cheeseborough, there are 22 central ambulance communication centers, 8 regional base hospitals, and at the bottom, 56 certified land ambulance operators. We, the region, are the certified land ambulance operator for the region of Durham. It's important to note that even though we are the providers of land ambulance services, our fleet and staff are dispatched by the province through the central ambulance communications centers. So by law, as the local land ambulance service provider, you're responsible for costs, for the proper provision of land ambulance services in accordance with community needs. You're responsible for ensuring vehicles, equipment, etc. You need to ensure that as a land ambulance operator, we're certified by the ministry. We need to meet response time performance plans, and there are a number of enforcement provisions under the Ambulance Act. A relatively new program, circa late 2021, is Community Paramedicine, and it provides clinical support to vulnerable populations at home. It is funded by the Ministry of Health and the Ministry of Long-Term Care, and Chief Cheeseborough may flesh that out in more detail in his presentation. Just a reminder, as a health department, this is our vision and mission. In terms of our organization in 2022, we had just under 725 full-time equivalents. That translate into a little over 400 FTEs for public health and around 320 FTEs for paramedic services. You've met my executive team. Their titles are listed there. In my office, I have 3 office managers overseeing health analytics and research, community and resource development, and health policy and equity. We have locations throughout Durham region. We have a headquarters and 11 paramedic stations with 12 to come later this year. And we have a number of offices and clinics throughout Durham region on the public health side. Just to give you a sense of the magnitude of our budget, in 2022, the total budget for paramedic services was just over $59 million. The provincial and regional breakdowns are listed there, and roughly speaking, the cost sharing between the region and the province is about 50-50. The province also provides 100% funded programming with respect to community paramedicine. With respect to public health, the gross budget was just over $54.5 million. The provincial and regional breakdown is listed there. Roughly speaking, the ratio between province and region is about 70-30. We do get 100% funding from the province for the Ontario Seniors Dental Care Program. I mentioned that we have two main vehicles to assist you in fulfilling your statutory duties. One was a online Board of Health manual you can get at durham.ca/Board of Health manual, all one word. This is one of the assets that's under the General Information tab, and it just lists the programs that fall under the portfolios of my executive team. There is another page to this placemat, and it provides a narrative as to what these programs are all about, so it's probably worth a look. The Board of Health Manual really is the repository for our foundational documents. I mentioned as well that in addition to the Board of Health Manual, the other main vehicle is our accountability framework, and we have two streams. One is program planning and evaluation, which I'll touch upon here, and the other is reporting. So I'm only going to mention a couple of the bullets in this slide. So I mentioned at our last meeting that for most of 2022, we spent time as a department preparing for accreditation. I'm pleased to report that yesterday we were notified that we have been reaccredited under the Accreditation Canada Cumentum program. And I was very pleased to learn that of the over 650 applicable standards, we only had not met 6 of them. So we're very pleased with that. The other thing I wanted to mention is with respect to our business planning and our annual review. So beginning in 2023, we will be reestablishing a health plan, which is really a compilation of our program priorities, which we track throughout the year. And when I get to the next slide, we will report out on our progress in implementing our priority programs at year end and in 2024 through our annual report, which we call a health checkup. The other thing, going back to accreditation, I will be reporting out on our accreditation decision and report on a CAP, Council Information Package info report, probably in the next couple of weeks. So those are the two pieces of our accountability framework, and I'll let you go through the bullets at your leisure. Finally, there are a number of current and future issues that we're tackling. Let me just mention 2 of them. So as you know, climate change is the existential issue of our times. So later on this year, we expect to be issuing some health vulnerability reports, a series related to climate change. And I understand we've been doing that work in concert with the CAO's office. The other thing I wanted to mention is the disruption caused by the pandemic really has taken a huge toll on our entire team. I know it has widespread impacts throughout the region as a whole, and it's had huge impacts on the health sector. So health human resources is a top priority for us, not only in terms of recovering from the burnout that the pandemic has caused my team and I, but also with respect to the attraction and retention of staff. Those are a couple of the top issues on the public health side of the ledger. And I know Chief Chewsborough will be getting into a couple on his side. They include offload delay and the full implementation of community paramedicine. We will be reporting out on our priorities when we report out on our health business plans and budget, and that will be coming to you in your March committee meeting cycle. And I would be remiss in not mentioning that we will be reporting out probably in your February cycle as a committee of the whole on an implementation plan for the Paramedic Services Master Plan that we presented to committee and council last fall. And so if you have any questions about that, Chief Cheesebro has the best line of sight. So, Chair, I'm sorry, and here are just some screenshots of a few resources that may be of use to you, your staff, your municipalities, your teams. This is the Health Department homepage. This is the homepage for health stats in Durham Region, including health neighborhoods. This is the home for Health Department publications. I mentioned Health Checkup, and I mentioned our health plan, which will be posted there. And I think that may be it for me because the slides are not advancing. So, Chair, happy to answer any questions. If committee members have any questions for paramedic services, my advice would be, but I'm in your hands, to wait to hear from Chief Cheesebro and perhaps wait at the end of his presentation to ask any paramedic services specific questions.
Dr. Kyle, thank you very much. We do have one, and Mayor Foster, would you be willing to wait till after the presentation and hold the question, and then we'll allow for Chief Cheesebro to move forward. But first and foremost, Dr. Kyle, I think on behalf of all of us here, that to the whole team, the work that has been done, especially in the past 3 years, has been commendable, and recognizing the needs and supports and the well-being more so. And we want to thank everyone for their work that they have done.
So we appreciate that, and every time you convey that to me, I do convey that to my team, and I know it's very much appreciated. So thank you for that.
Yeah.
So I'm going to yield the lectern to Chief Cheesebro, and as I said, he will be introducing his executive team, and so over to you. And I see Deputy Chief Riches has joined us. So,
and welcome, Chief.
Good morning, Chair and members of committee. I'd just like to take a quick minute to recognize a couple of the senior members of my team as well, so people are aware. I have Acting Deputy Chief Jake Svanda with me today, as well as I have Deputy Chief John Riches. And of course, we have to also take a second to acknowledge the true stars of our division, which are the frontline paramedic staff out there responding day in and day out to deal with the current emergencies, as well as over the past several years of the pandemic. So congratulations to them for all the hard work they've done as well. In addition, I just want to take a quick minute to make an acknowledgement here of someone else in the room. So as many people have probably heard, my Deputy Chief Riches is going to be moving on. He's had the opportunity to assume a role of chief in Waterloo, and I'm very proud of that. He's done a great deal of work here in the region. Certainly during the pandemic, he helped out greatly with the vaccine rollout. He's been kind of my main lead for a number of committees and positions within this. So he is going to be greatly missed. And I'd like to take a quick second just to acknowledge the time John put in here. He's 26 years in the business and basically with the region since the download. So thank you, John. All right, so on to our presentation. So quick update from paramedic services. The focus of this is probably going to be more on the offload delay so people understand the impact, but we'll start off with a little bit of update on the Seton response station build. So that's obviously an ongoing project. John was just out there yesterday dealing with our team from Works in the build, and we've been advised that although I indicated in the slide we're anticipation completion by the fall, that still stands. However, we're going to have a graduated, I'll call it move into that location to ensure that we can get everything up and running in the appropriate kind of fashion and there are no hiccups along the way. Anytime we have a new build, there's always been a few hiccups. So we anticipate being in there sometime, most likely in around October. And then we'll be in what I would call full rollout from that station, pending any unforeseen delays by January of 24. We've been very fortunate with the support of this committee as well as council in the region. We have started that vehicle already. So what we're calling as our Seton paramedic response unit has started. We're currently deploying it out of our Pickering location. So we do have that additional resource in play already. A little bit about our paramedic services call statistics. So we're sent out on 4 different priorities, essentially, as our primary ones by our Central Ambulance Communication Center. There's additionally something called Code 8s, which are referred to as standbys. And basically in 2022, we responded to around 95,477 priority 1 to 4 calls and an additional 46,750 priority 8 calls, so those standbys. The number of patient transfers is expected to continue to increase as the population increases, ages, and people live a little bit longer. In addition to this, we do have to consider, this is our current dispatch model, and the province has recently rolled out a new dispatch model called MPDS. We're not sure exactly where we're going to be with respects to our dispatch center and the rollout of this. I anticipate by fall, but unfortunately, we're at the province's whim with how that actually gets rolled out. It has started in Mississauga and from their CAC, which deploys Mississauga as well as Halton and a couple other services out that way. And speaking to the chiefs from that area, this has had an amazing impact on paramedic services. Not necessarily decreasing the calls, but properly prioritizing the call so we can get the right resource to the right person at the right time. And those lower priority calls, we can adequately delay to ensure that the higher priority calls get serviced in an appropriate manner. A little bit of the call stats on there as well. So I basically provided 2018 right up to 2022 for you. So you can see we've had about an 8.7% increase from 21 to 22. Again, our patient transports. So in 2022, we actually transported 51,748 patients. That's a continuous sort of increase. You'll see the dip happened in 2020, obviously, with everybody staying home and less people traveling and many people afraid to go to the hospital, to be quite honest. In 2020, there was a rapid reduction in actual transports about 6,000, 6,500 from where we currently stand. But that was just a sort of a hiccup because we have traditionally trended in an upward fashion on those. Offload delay. Well, many people have heard about it. It's been all over the media. And all different services are identifying this concern. So basically, the province defines parameters with which the hospital is anticipated to be able to offload a patient. So from the time the ambulance arrives to the time the patient becomes the responsibility of the hospital, the province has indicated a 30-minute window is what is deemed a reasonable transfer of care time. And to be quite honest, I would love 30 minutes. I'd love an hour, to be honest, but the reality is that's been one of our biggest challenges going forward is offload delay. So if you take a look at kind of our offload delay metrics for hours, I broke it down month by month for you for 2022, and you'll see the numbers are huge, into the thousands on a fairly consistent basis. I kind of laugh at the February dip, but February has 28 days. So, I mean, of course, there's a bit of a dip in that time frame. Our 90th percentile. So the 90th percentile is a number that defines how many minutes that you're basically anticipated to be offloaded in. 90% of the time or greater, you will be offloaded in less than this time. The downside of that is you can see how huge that number is. So in December, 172 minutes. So you're looking at almost 3 hours that an ambulance is sitting in the hospital for the greatest number of time. So that has a huge impact on our response capabilities, and that equates to why you heard in medias and things like that what some people, services recognize as code zero, or some services referred to it as code red, depending on the service. But this has a huge impact on the operational fleet and our ability to respond to emergency calls when we're stuck in the hospitals, managing patients that are essentially, in our opinion, the responsibility of the hospital. When you compare again sort of where we were with 2021 and 2022, our offload delay time, and this is per month, you look at the numbers, they're significantly different. We started to creep up in around August, September, and that's where it continued to kind of evolve from then. That was when we were into pandemic was well established. We were seeing the impacts on the human resources side of the industry with respect to hospitals and all the other challenges that were experienced in there. And the HHR issues at hospital became a trickle-down effect for us, and it transitioned into offload delay for our staff as well. If I want to compare the 90th percentile again from 21 to 22 to kind of give you an idea, if you look at the earlier months, because again, as we started to creep up later in the month, but 43 minutes, 48 minutes, in January, February, that's a reasonable time with the call volumes and the impacts on hospitals today. I think, to be quite honest, the 30-minute mark set by the province is a little outdated now, based on how things are going. But that's the number that we generally report on. But that 43, 48 minutes is a reasonable amount of time to safely transfer care of a patient to the nursing staff or the hospital staff. So I'd be quite happy, like I said, with that numbers. And that didn't have a huge impact on our response capability because crews were getting out. Because again, that's the 90th percentile. So there's still some getting out quicker than that, obviously. When I look at costs, this is kind of the depressing part. You look at the cost, and I evaluated this in two separate ways. So the blue line basically is the cost based on the MBN unit hour cost. So I suspect the members here are very familiar with MBN, the municipal benchmarking, and we define a unit hour cost for ambulances through that. There's multiple factors that are looked at. They look at call volume, they look at population, they look at overall operating budgets. A lot of factors are considered into that. So it gives you a cost per unit, and that's all the factors that are considered with operating that vehicle. So it's wear and tear, it's fuel, it's staffing, it's equipment, all those different things. The orange line is simply wages alone. So I basically averaged the wage of the paramedic staff working on that vehicle and took only that and came up with that number. So if you want to look at the numbers in kind of a total value, if we use the MBN in 2022, we're about 8.2 million. It costs this municipality an offload delay. And if we use wages only, it's still about a 3.1 million cost to this municipality for our offload delays at the hospital. So it's a significant number, and it's dramatically impacting our operations side. As far as a provincial update, what's going on provincially. So our regional chair and CEO continue to support RDPS in meetings with the hospital partners as we attempt to mitigate offload delay. The hospital has went to a third-party consultant to provide some insight and direction, and my team has been working with that agency to try to provide some solutions that we can jointly work on to try to mitigate some of these. The HHR issues continue to be a challenge, not only in our division, but across hospitals as well. So we are working towards that, and we recognize that is part of the problem. But there's many other solutions that can be initiated to try to mitigate some of these challenges as identified by other municipalities surrounding us. Places like, for example, York. There's a couple of hospitals in York that essentially have virtually no offload delay. Their volumes are almost the same as ours. So it's basically strategies that can be initiated, and we can hopefully work with our partners to get that. And again, we've had great support from our chair and CEO with respects to that. We've received notice that our new provincial radio system is going in and should start to install in our vehicles around April of 23. Interestingly enough, the radios that are currently in our vehicles, the original deployment of those towers was 1967. So I can actually say they're older than me. And then the actual radio units within the vehicle itself, we got those units back in the early 80s. I believe it was 1982. So those radios are still from the early 80s. So it's kind of like we equate it to the Flintstones. It's a little bit of a bird you speak into and he flies over to the next ambulance to communicate. So we're finally getting into new technology. I had lobbied for a long time the province to try to hop onto the regional next gen system. I thought that would have been a great opportunity. And speaking to our next gen partners, they said certainly we have capacity, but the the provincial government said no way, we're not going to share with anybody. We're doing it ourselves essentially. So they will be rolling out the new system, and that will apply to both OPP. Paramedic services across the province, as well as things like the MNR and stuff like that. We all use the same radio network. So that'll be beneficial to all of us there. Provincial funding for the community paramedicine program, it's set to continue for now for 23-24. That has provided some positive impact on our staff and on our call volume. It's very minimal on the call volume. People often quote that this will have a dramatic impact on call volumes. It really doesn't, to be quite honest. What it does impact, though, is the individuals that are calling on a consistent basis. So we've had staff that are members that have called 20, 25 times per month are not uncommon. And once we initiated and got them involved in the community paramedicine program, they might call twice now. So those individuals, it's had a huge impact on them. They're living better lives. And at the end of the day, the goal is to make them more comfortable and provide that service and try to keep them out of the hospital system because, it's just there's added stressors on the hospital. The reality is it's a low number in the grand scheme of things. I believe we have just over 900 clients registered in our program right now, and the number does continue to grow on a fairly consistent basis. So the team on our community paramedicine side has done great work with getting this implemented, and we're having a positive impact, and staff are receiving regular kudos from some of these folks on a fairly consistent basis, and they're sending to us as well. So very positive spin on the community paramedicine, and very grateful the province is continuing to fund that at 100%. As I mentioned earlier, when I talked about the CTAS piece, the provincial changes to the dispatch center have started. This MPDS it's going to be a color-coded dispatch system. So currently we go priorities 1 through 4 for emergency calls, priority 8 for standbys. We're going to be going to a color code dispatch. So green and yellow are low priority calls. And under the new directive, a green and yellow call can wait for a minimum of 3 hours. So staff or individuals will be told when they call if they fit the green or yellow threshold. You're a green or yellow, just so you know, it'll be about 3 hours before an ambulance gets to you. That's causing some real challenges in the areas with our fire services. Not here. We have a great relationship with our fire service, but in some of the other areas where they get dispatched, for example, to car accidents, because that falls under the mandate of fire service, and they do a great job with that. But if the patients aren't really injured and it comes in as a green or yellow call, the fire department has been waiting at the scene until the ambulance arrives instead of just clearing it with the police approval. So that's causing some challenges. But again, I know I have a great working relationship with all the chiefs within our municipality, and I don't see it posing a problem here when we do roll that out. But we will. I'll have meetings with the group ahead of time, so we'll be able to hopefully mitigate any of the operational challenges that may come out of that. And we are coming forward with a new treat and discharge directive. This is from the province as well. So they have directives that under certain conditions, paramedics can get called, and we no longer have to transport those patients. So there are things like diabetic emergencies, seizure disorders, believe it or not, a heart dysrhythmia or arrhythmia called like an SVT. So we can treat these now at the residence and not transport the patients. And in fact, we don't have to necessarily get patient approval. We can just tell them we're not taking you. We're not taking that approach here in Durham. Our staff are still going to offer the transport capability to the individuals because we don't want to be seen as refusing to transport somebody. So we're going to continue on with that. But the reality is we can consult with a physician immediately. The patient will be able to hear the consult with a physician, and we'll be able to say, okay, it's safe to leave that person at their residence. So as long as there's a bunch of criteria to it, so it's not as simple as I just kind of made it sound, but we are going to be implementing that as well. That will have very little impact again on our overall call volume when you want to look at it from that perspective, because the very focused study that I'm going to call it right now, or they're calling it early adopting. That very small focus is on really 3 conditions, and that isn't a huge subset of our calls. SVT, for example, I did a quick review, and last year I think we did 27 SVT calls where we actually treated the person. So 27 out of 57,000 patient transports, or 51,000 patient transports, isn't exactly a lot. But it's a step in the right direction. The government is seeing this as a necessity, and programs like this have been initiated in places like the UK and Australia for many years, and they've just recognized that our province is recognizing that we have to accept more risk within our paramedic services and within that client group because of the added stressors on our hospital system currently. So this is one of the things they're going to do to operationalize and try to deal with some of those problems. I think that brings me to the end. So that's it from my presentation.
Thank you very much, Chief. And I have Mayor Foster.
So thank you, Madam Chair. And Chief, I'm going to have just one question for you. You spoke briefly to York Region not having the offload delays and programs in place. Are there things that we need to be doing? So I know the chair and the CAO are working on this, but beyond the chair and the CAO, us as councillors, the mayors around the table, it sounds like there are solutions that we aren't taking advantage of. And when I say we, I'm talking about Lake Ridge, perhaps the ministry, maybe us.
Yeah, the challenge is each situation is a little bit unique, and the capacities within each hospital network are a little bit different. And that's why we're working closely with our hospital partners. So, I mean, I guess, from what you can do as committee members and members of council is just support, continue to support us the way you have, continue to support the chair and the CAO as they continue to basically speak on behalf of the many members here and us. So I think that's really the focus. As I said, every situation is a little bit unique. So to deal with, it's apples and oranges, unfortunately. We can't say you can do the exact same thing at Lake Ridge Oshawa because it's not the same system that exists within that corporation.
Okay, good. I was hoping for a magic wand that we could wave. Didn't expect it. Chief, thank you. Doctor, if I could ask you, I guess a high-level question. We, as political representatives, very frequently we're hearing concerns from the public on, not surprisingly, healthcare. On the one hand, I am listening to the government. I'm listening to my local MPP who is talking about these massive sums of money. This government is spending more money on healthcare than any government has ever spent. On the other hand, we're seeing some very, very deep and disturbing problems with the healthcare system. So the question is, one, is there an ability to educate us as political representatives in terms of gaps and things? I guess it's one question, is things that we need to be advocating in an educated way. And I'm thinking, Mr. Chair, I'm sure that you're going to be involved in the pre-budget consultations that are coming up. There's a budget coming that we could be educated and sort of hit them with some fact as opposed to what is maybe less than factual.
So the short answer is maybe. I think government's attention is focused mainly on acute care for the reasons that the chief indicated, offload delay being a prime example. There are huge health HR systems across disruptions across the health sector, and the solutions that have been announced by the province don't necessarily impact us. So changes to advance registration of internationally trained nursing and medical graduates, for example, comes to mind. Changes to scopes of practice. So just this week, the scope of practice for pharmacists has changed, which enables them to assess and to treat 13 common ailments. So the problems government is focused on are largely acute care, maybe primary care. What we can educate you on are the problems in our sector. And I think the key problem from an acute care, primary care perspective, you've heard from Chief Cheeseborough, it's offload delay. And in addition to working with our hospital partners, as I indicated, behind the scenes at the staff level, we're looking at enhancing paramedic services through the implementation of a paramedic services master plan. So I would ask you to have an open mind to listen to that report when it comes before you. Beyond that, I'm a bit uncomfortable talking about problems in other parts of the health sector that don't necessarily impact public health. But if there are opportunities to do so, I will certainly take that back and look for opportunities to educate you about those things. I should say that from a news release perspective or a headline perspective, every couple of weeks, I add to the council information package health information updates, which are a range really of either headlines or products that touch upon us, Government of Ontario, Government of Canada, other organizations. They're there for your information. And so on the margins, I attempt to do that on an ongoing basis.
So it sounds like an offline discussion, and I'll buy the coffee. But I'm thinking where we can be again as members of council. Maybe have some specific points of advocacy that we need to bring up to the MPP. So I'll give you a shout. Thank you. Thank you, Madam Chair.
Thank you, Mayor Foster. And Councillor Jubb.
Thank you, Madam Chair, and through you to Chief Cheeseborough. First of all, thank you for what you do and what your team does, especially throughout the pandemic. Being a firefighter for a decade in Brock, it's always happy to see you guys coming, for sure. Just to expand on the offload delay, I'm not totally convinced that's our only problem in Durham, to be frank. I'll use Beaverton as an example. It seems like we see York and Simcoe County coming in for the backfill more often than we see Durham. And that is concerning, to be quite honest. Where do we sit with compared to other neighboring municipalities, specifically for resources and proportionate to the population? Are we about even to York or Northumberland or Simcoe County, for instance, or Toronto? Or where do we sit? Or are we lacking resources, I guess is the question.
So through the chair, so we can always use more resources. I mean, the unit hour utilization by our vehicles is very high here in Durham, which basically means the amount of time they're tied up on actual calls is very, very high. For our comparators, I would say we're very close to York. The challenge we have within Durham is our geography. As everybody knows, it's 2,500 square kilometers of huge space, and we go, to your point, all the way from Beaverton down to the lake. The reality is when our resources get taxed in the core, that's why you're losing, I don't want to say losing, but redeploying your resources from the north down. That's been what's happening. And to be quite honest, I concur that it's not only just offload delay, but if you consider that we had 30,000 plus hours of offload delay last year alone, that's the equivalent to essentially having 4 ambulances in the hospital 24 hours a day, 7 days a week. So that therefore means our staffing numbers are down by 4 ambulances. So if those were back in the system, that would help us balance that coverage out more effectively to maintain those resources in the north. But from a comparator perspective, we're pretty close. Actually, funny enough, the service Deputy Chief Riches is going to is a great comparator, believe it or not, Waterloo, as far as the number of units and things like that. And they're experiencing the same challenges as well. but they don't have the same geography challenge we have. So that's part of our issue as well. But definitely we could use additional resources. And as Dr. Kyle mentioned, through our master plan, that information will be coming forward to everyone to take a look at. But you know, I would still argue that offload delay has a huge impact. It's not the only impact, but it's definitely one of the biggest.
Okay, and that's fair enough. And I guess I'll use Beaverton as an example. And sometimes there's no EMS there all day, right? Because exactly what happens, we need it down south, which I understand, but that's filling a huge void up north. Because using Beaverton as an example, it's a great example. Beaverton's 40 minutes from any hospital, whether it's Aurelia, Lindsay, Port Perry, Uxbridge, or Newmarket, right? So we're already 40 minutes behind. So to have no EMS there is a problem, and I think that's a problem we need to find somewhat of a solution for. And I'm looking forward to talk offline on that for sure. But what, just for the public, what Brock has done is actually I put the motion forward last year to increase our tiered response time for medical calls just to fill that gap. And unfortunately, that's not overly fair for our taxpayer because we're already paying for EMS services that we're not getting because we're using the resources to the south. Now our taxpayer is paying twice for that, which is concerning, but we had to do something because we were getting reports of elderly folks waiting for upwards of an hour in distress, right? So at least we're providing some level of care. We don't necessarily want to do that, but we had to do that. So, yeah, unfortunately, let's talk offline, but definitely some major concerns there. But thank you.
Is there any further questions? And seeing none, I do have a couple. And Chief, just with relation to the recent, with the hospitals and the delay times for the emerges, has that had any positive impact, like with the offload as well too in the last few months?
So our numbers are still quite high. I get weekly reports from my data analyst, and we're still, you know, upwards of 1,000 hours at peak. So we haven't seen a huge positive swing for our offload delay. Unfortunately, it still continues to be a challenge in that area.
Okay. The one thing too, just want to, your stats are facts. Nobody can deny that, and especially with relation to the cost of the implication on healthcare as a whole. It is one that I think honestly it's a great stat to carry on forward to the ministry as to we're spending $3 million on a wage time where we could be having our staff out helping giving support. Now, the other with the treat and discharge, the education side of that is one that when probably the paramedics are arriving and the reason why a person may have called for an ambulance is with the expectation they would be transported with the ambulance. What has been, and I know it's only been 27, what has been the reception to a treat and discharge? Is there a lot of opposition? Have any of outside of that 27? The original was to do a treat and discharge, and absolutely not, you're taking me to the hospital. Is an education to the community. This is the way we will be moving forward, a component that we need to be looking at.
So with respects to the treat and discharge directives themselves, there hasn't been a lot of pushback, and not all services have started this yet. As I said, our education piece starts in February, so we'll be doing it probably April-ish before it'll be implemented in full capacity here within Durham. Generally speaking, I'll take our diabetic client group as an example. They never want to go to the hospital, to be quite honest. You know, they have a diabetic episode, generally are hypoglycemic ones, the ones that have an unresponsive period or a decreased levels of awareness. They're treated with the sugar or a glucagon by our paramedic crew. And once they're awake and alert, they would rather just eat something because they know what their underlying condition is and they understand it. So for that reason, they're very receptive to this. Our SVT group, so that subset of the heart arrhythmia group that I'm talking about, if they're familiar with their own conditions, so there are certain medical conditions that cause that, if they're familiar with it, they're going to be quite receptive to remaining at home, because if we can treat them and they can just stay at home now that their arrhythmia has been fixed, they would stay at home. So I don't think there will be any challenges with the group we're talking about. The challenge will be our seizure group or a post-ictal group. because quite often they're still a little confused after the seizure episode itself. And, we're not going to wait around for the person to become fully alert and be able to make that informed decision about remaining there. We would just be transporting them if that's the case. So again, it's a small subset of groups right now. I do sit on the provincial committee for that, so I have voiced some of the concerns. And to be quite honest, the biggest concern will probably be more from paramedics, because this is a change of mindset. Our mindset is we pick patients up, we bring them to the hospital. Suddenly you're telling me I don't have to do that? It's a complete 360 for the paramedic mindset, and especially the arrhythmia ones, because we have an understanding of all what's going on with stuff like that. So the province recognized that, and they said, yeah, we get it, but at the end of the day, we have to do something to help relieve the pressures within the hospital system. And albeit small, this will have a little bit of an impact on dealing with some of that. As far as notifying the public and making some sort of a campaign related to that, I don't think we really need to, because I think that might potentially install some sort of fear into staff or public members that you're not going to take me. And we're not saying that at all. If they want to go at the end of the day, we will still be transporting them to the hospital.
Okay, and I appreciate that. I have one more question. I did have Mayor Carter, but I think he's dropped off. With relation to the recent announcement about the urgent care and the billing hours, are we keeping that on our radar and the impact of what that may have onto calls into the paramedics, that the urgent cares some doors are closing?
Yeah, so we're gonna keep a close eye on that and see how that pans out. One of the conversations I believe Deputy Rich has had with our local hospital group, and they were, this is something they've been pondering as well, as getting back to an urgent care right within the hospital setting itself. And some hospitals have already adopted that in other municipalities. So that's something they're looking at considering as well. And in that case, it would likely be a 24-hour urgent care. And that would just defer some of the group from within that. So we'll watch it closely to see if it does impact us. I don't anticipate it will have a big impact on us with that change, but there's a potential that it could. So we will watch that closely.
Okay, appreciate it. And thank you for everything as well, too. Mayor Carter, I did see your name. Do you have a question?
Thank you very much, Madam Chair. I just wanted to say good morning, so thank you very much. And Chief Cheeseborough, thank you. All the best to your team. You guys do an incredible job under very difficult situations, so keep up the great work.
Great, and thank you very much. So I'm going to move on. If there is no more questions, I'm going to move on into the agenda, and under health, under reports, report number 2023 MOH -1, and it's the Region of Durham Paramedic Services Ambulance Vehicle Purchase and Standardization. Mover by Mayor Foster, second by Councillor Brenner. Any questions? I'm seeing none. All in favor? Moving on to social services, we have no correspondence. We have one report, and this is the 2023 pre-budget approval to establish a behavioral supports Ontario virtual mobile team operating out of Fairview Lodge to support the Central East Health Region with funding provided by the Ministry of Long-Term Care. Mover, please, Councillor Brenner, second by Councillor Dove. Any questions? You are an easy group. All in favor? And our next meeting is February 9th, 2023 at 9:30. I need a mover to adjourn. Mayor Foster, Councillor Anderson, and all in favor. Thank you.